When I completed my super specialty in critical care, I came back to Chennai and settled as a consultant in a good hospital, a big corporate hospital. I joined as a consultant. So when we meet people, our own colleagues in our meetings and regular exchanges, many times they come to me and tell me that there are many hospitals in and around, especially in the suburbs of Chennai, also many rural areas. Those hospitals need ICU support. So they come and ask us, saying that can you suggest me some doctors to work like that. So those days I saw that there are some groups of people who do group practice. Like there are a group of ICU doctors. They whenever there is a requirement by the hospital, they share the duties, and also they recruit some people and then send doctors. That's like a group practice or organizing doctors for ICU. We tried that initially. The problem is when you send only a doctor in the ICU, the quality of ICU you cannot improve, because ICU is not just a doctor, it's a whole teamwork. Later we observed there are some rural areas which asked, and then there are many people do so-called tele-ICU, where the consultant will be sitting in a remote area, in a city actually. In a remote area there are cameras, and then you see and advise the local doctors there. For even there, to improve quality, to make sure that you get the required standard quality, the entire process has to have, the baton exchange has to be proper. And there also we found out some problems that most of the times the hospitals, they say only for sick patients they ask for consultation. Normal patients they don't ask. Now the purpose is defeated. What is the idea? To give the highest quality of ICU services wherever we go. In corporate hospital where I was working, it was possible, because everything you ask, it will be available. Everything for that matter. And all the lab, radiology, and any drug you want, the kind of people under you are extremely talented, and you just give an order, it will be taken care of. So that's a very comfortable area to work. Whereas you move out, go to the small hospital in suburbs or in rural areas, there is no system in place. So that is where we tried the so-called providing doctors or providing nurses or group practice or doing tele-ICU, where we observed that the giving standard of quality in the hospital, it was not to the fullest extent. That is when we realized the solution for this is you have to do entire 360 degrees, whole ICU should be under one leadership. When it is under one leadership, what will happen? That when you even the observation of the patient, diagnosis, giving an order, and then how the system is working to the lowest level, to the lowermost, juniormost nurse to handle or follow the instructions and give proper care to the patient. Unless it is under one leadership, it cannot happen. So that is when we thought to launch something called drop-in ICU. Drop-in ICU means if you have a hospital where we take only the infrastructure, where you have space and machinery and equipment, and that you take, but entire systems, processes, protocols, teams, starting from doctors, nurses, technicians, different levels of nurses, nursing supervisors, shift in charge nurses, staff nurses, junior staff nurses, technicians, ward boys, patient counselors, and then the teams like infection control teams, everything, including the maintenance of the machines and other things, those total, including autoclaving. We have to have control on the sterilization processes. You have to have control on the surroundings of that place, everything. When you take it under control, under one leadership, over a period of time, you can actually create the quality of care that is equivalent to international standards. So that is when we launched this model called Cipaca, which is nothing but a drop-in ICU concept where you collaborate, partner with the hospital and take the space, and then we operate the ICU services with all the teams put together, and we become accountable for overall care of the patient, and including any issues, medical legal issues, everything. Foolproof system will be launched and then it will be taken care of. Initially we had of course troubles in collaborating with people, making them understand, and then of course getting the teams and making them operate, for which yes, we also took some time. It took us almost 5 years to actually do our research, background analytics, and then creating the infrastructure to be able to operate an ICU wherever it is, it is needed. And I am happy to share that today across India, anywhere, length and breadth, if a hospital needs an ICU, in a span of 1 month, we have the bandwidth to launch an ICU and operate it. And in a couple of months' time, or max 3 to 6 months' time, you actually set up all the standards, processes, protocols in that hospital and make it a center of excellence in that place for critical care. So that is how Cipaca began, and that is how it is going on right now.